first thank you both. I know you're both on the front lines of cancer research, cancer treatment, et cetera, and I'm sure by default now helping with so many different aspects of what COVID-19 is doing, and unfortunately having, as we know, lots of effects for cancer patients. As you know, today, many around the world are feeling what cancer patients feel every day, right? I mean, it's now we're scared, we have anxiety, we're worried about what's happening tomorrow, et cetera. We've seen the Alliance, we've seen about a 30% increase in people that are coming to us. And I'm actually going to read a little bit about the stats here. This will be no surprise to you, but the main reasons why we're seeing increased delayed clinical trials, fear around managing the exposure to the virus due to their compromised immune system, lack of access for screening and or delayed scans, anxiety about restrictions in terms of who can actually accompany them to treatment, and overwhelming stress around the financial insecurity and job loss. So those are the biggest things. And then in looking at this data today that's coming out from our helpline and all of the different folks that come to us, the biggest thing is that they say is they're just afraid. And I'm sure you're hearing this. So, I first want to maybe start with, what are you guys seeing as the biggest hardships in terms of, treating patients during this epidemic? And I'll start with Dr. Marshall.
Yeah, thanks, Michael. And I'm sure Chris has a lot to add on this. I mean, first, our message to patients here, at least, has been that we're open. We are having to make decisions and modifying things, but cancer care is not elective. So we're open. We are doing surgeries. We are giving treatment, chemotherapy. We are seeing patients, whether it's by televisits or in person. And so we're trying as much as we can to maintain. When we first started this, the question was this going to be a month-long venture, maybe 2 months? And now that we're sort of plateauing in many ways, we're looking longer out. Is this the new normal for a while? And so, it's okay to make short-term plans, but now we're making different longer-term plans. And so, it's totally changed everything about what we're doing. I might actually just begin also by saying that while we have been setting up things to be in support of the real frontline workers, those in the ICUs, infectious disease, hospitalists, and the like, yesterday for me was the first day I really sort of felt this, with one of our team getting infected or testing positive, and really hearing from our ICU colleagues and others about what they were doing day in and day out. And it sort of, for the first time yesterday, changed for me from something of a bunch of numbers and graphs that I'm watching to really realizing that these are people. These are all people, both on the medical side and on the disease side, on the infection side. And so I think what we're seeing here in Washington is honestly the same as what you said, is a sense of depression, of sadness, of uncertainty about what the future holds for all of us, for everything. All the list you created is running down everybody's mind every day. Chris, what's it like there?
Yeah, so John, I think that's incredibly well said, and I think it's that idea of the uncertainty, right? And I think our patient population lives with more uncertainty than really any other patient population. And so to a certain extent, I think our patients have really taken this, if possible, more in stride, than any others, because, our patients do live with a lot of uncertainty and a lot of difficult things going on. But having said that, John's right. I mean, this is a completely different level. I would say that it's the uncertainty that causes a lot of concern and worry about, what we do with treatment. Is it safe to come to the hospital? If I come to the hospital, will I be in contact with a patient that already has COVID? Am I at greater risk if I do get COVID to have even more complications? And so these are the risk-benefit conversations that John and I and so many other practitioners are really having these conversations every single day with our patients and their families about, is it safe? Is there a way we can make you safer? Can we continue on with treatment? And John is also 100% correct. Cancer doesn't care about pandemics, right? And so a lot of our treatment, just as John mentioned, we're continuing to treat patients to treat patients aggressively, to offer therapies that our patients need. And so it is definitely a somewhat overwhelming time, but I'm really proud to say that our patients, our practitioners have really stepped up to the plate during this time. And also to kind of echo what John had mentioned about the heaviness of this, you can feel it. When you walk into the hospital, I'm sure our patients can, especially when they're greeted at a door by a screener, which is something that, you know, probably has never really happened to them ever. And when you're in that environment, there's an underlying stress that exists that I think is important just to recognize and understand, both on the patient side, but on the practitioner side as well. So I completely agree with everything that John has said.
Yeah, so I think the next question would be, just because the majority of people that will be listening to this now and that will listen to the recording of it will say, and we got questions ahead of time, or, you know, that are nervous about coming in, is what precautions are you taking? And what does that look like in terms of preventing, you know, patients, cancer patients from getting the virus? I don't know who wants to kind of take it.
I'll go first. I mean, you know, I think, you know, our staff calls patients the day before, 48 hours before, screens them for symptoms to remind them. We are pushing as many visits as can be done by televisit, where now about half of our total visits are done by this kind of format. When we can get away without seeing them in person, but still a high percentage of patients are coming in to be seen. Then if they meet that criteria, they get screened at the door. As Chris said, we then do a secondary screening in our cancer clinic. Turns out when it's cold out and you use one of those forehead shooters, it's off. So we've been seeing even a discordance between what happens at the door and what happens coming into our clinic. And so then we, you know, we ask questions again. Everybody gets a mask when they walk in, and hand cleaner, and then we see you. We take your vitals and the like. And people are making it all the way to our exam room, being still missed, just to be fair. That it's not until that MA who's taking the blood pressure then asks a little further, and then the patient says, oh yeah, I've been coughing for 3 days. And then we immediately send them to a special clinic where they get screened right away. And now we've got testing that can turn it around pretty quickly, sometimes within minutes, sometimes within hours, to where we can tell that patient what's going on. And so, I mean, that's basically, so it is safe. It is probably safer than the grocery store, okay, to come to the hospital, all right? And I think that's very important. We are all making our decisions to go to the grocery store and hunt toilet paper, but it is safer, I think, to come here than it is to go to the grocery store. Chris, what do you think?
Yeah, I totally agree with that statement, because the precautions that are taken in a hospital are just obviously so much greater than you know, kind of general public places like Costco or the grocery store. I think the procedures have largely been relatively the same across most centers, and so you know, everything that John has said is exactly what's going on, not only at our institution but at so many others. You know, you think about even like infusion units and infusion bays. You know, we're spacing out patients more there than we ever have to give you know, patients that distance that we believe is critical. I'll also second what John has said about testing. I mean, you know, with patients and also with staff members, if there's any concerning symptom whatsoever, a cough or anything like that, they really are getting tested. And with the testing ramping up, we can obviously test our patients at a much higher rate. But even like with our staff, to that point, when this all started, I had one staff that came in with a fever and a cough, and it took 6 days to get the testing results back. Now, just as John has said, I mean, we can get a test and like within an hour, we'll know whether a patient has tested positive or negative. And so I think that that's been a tremendous ramp up. And also to kind of second what's already been said, but, you know, if you think about telehealth visits and virtual health visits, this is something that, you know, John's been probably talking about this for many years. And really, you know, medicine, as we well know, has a tendency in some cases to move fairly slowly. Here, telehealth and virtual health visits have been pushed into the 21st century like a rocket ship. And so all of a sudden, something that probably would have taken months to years to really implement, we really did all kind of start doing, and I think successfully, within a week. And I think that is actually one of the good things, is that, yeah, we can help patients prevent exposure by just not bringing them to the hospital if they don't absolutely have to be here. So unless, you know, somebody has to be treated or has to be seen for a physical examination, this has been a really, really nice tool for doctors and practitioners to be able to see patients without actually having to be in the same room.
You're on mute, John.
I want to follow on the telehealth discussion because, you know, I'm just crept back from my sabbatical, so I've now done a total of 2 telehealth visits, and one was a brand new patient, and the other was just newly diagnosed, and the other was an end-of-life long-term patient of mine. And I have to tell you that in both of those cases, it was like my doing a house call, right? I saw them in their space, one in their living room or dining room, one in their bed. You know, the house call that I've always thought would be a nice thing to do in our line of work, I now have a way to do that. It was really a much more intimate, you know, I wasn't in the uniform, I didn't have my white coat on, it was more personal, more intimate, more focused. And so for much of what we do in cancer, I actually think this technology may be better than coming to a clinic and knocking on the door and the formal show, if you will. So while it has its limitations, I think there are elements of telehealth that's going to, for our cancer patients, make life better.
Yeah, that was going to be my follow-up question, which was, you know, what if someone's anxious about, you know, do I get the same type of care via telehealth? I mean, I think you answered it, but is there anything else that either one of you would add in terms of, you know, what is the line? I mean, obviously you're going to recommend them coming in if there is a line, but what should they be thinking about in terms of advocating for themselves for in-person versus telehealth? Yeah,
and so, you know, again, I don't always want to harken back to this idea of risk benefit, but it really kind of comes to that point of, you know, what is the risk of me coming in or going out in public versus can I achieve the same goals I want to achieve with my healthcare team by doing it virtually? And if the answer is, well, there's just a marginal risk of just being out in public when I don't necessarily have to, and I can do exactly what I want to do just by kind of doing like a Zoom call, it literally looks just like this, right? Then I think it's a pretty easy answer. That if you don't have to go out, then why take that risk, and why not just see your doctor from the comfort of your own home? And obviously, you know, I don't want to overplay it because I mean, I love seeing patients in person. There is, you know, obviously an interpersonal interaction that happens with in-person visits that's really, really hard to replicate online. And we certainly know that because everybody that's joining this webinar has been on about 1,000 Zoom calls, I'm sure, by now. But having said that, you know, here, if we don't absolutely have to see a patient face-to-face, it is, just like John mentioned, just a great way to interact with our patients and keep them safe, especially, you know, while we're worrying about the peaks of COVID-19 and the risks of it.
And I think that you say face-to-face, if you come and see me here, I won't be face-to-face. I'll look like this. So it's true. And so, you know, we can now do this. I think probably Chris is doing this too for our even inpatient consults. Some of our most sick patients where our most often difficult discussions we hold are there. If I go in to see a patient in the hospital, I'm all gowned, I look like a spaceman. But where if I do it this way, even when they're in their room and I'm just outside in the hall or in my office here, I can see their eyes, I can see their mouth, I can see that they're understanding what I'm saying. And what we do for a living in cancer is read people. And it's very, very important for us to do that, and it's hard behind the mask. Now, on the flip side, there are times, if I'm going to treat somebody with chemotherapy, I want to eyeball them in person. I mean, because we're about to embark on a cycle, whatever that, whichever the regimen is, and I want to make sure that they're up to it. And it's very, this is better than a phone call, but that's the line for me when I would like to see that patient, if I can, for particularly a more aggressive regimen. But let's say they're on capecitabine or Xeloda, and they've been on it for a while, and it's just time for their month to come in and get their blood tests. I can probably do that by video pretty easily.
Yeah, so let's. Oh, sorry, Chris.
I'll add on and just say I totally agree. If we have to examine a patient, and sometimes you have to, you got to listen to the lungs, or you have to palpate the abdomen. There's certain times where that has to happen, and you can obviously do that with virtual health. Although you can tell people to kind of push on their abdomen, which can sometimes help. I also kind of keep in mind that just remember that a decent percentage of all patients that have tested positive for COVID-19 are healthcare professionals. And so not only are you protecting yourself sometimes by doing these virtual visits, but you're actually helping staff as well. I mean, kind of keep in mind that, even for our medical assistants and our nurses and our nurse practitioners and our doctors, I mean, everybody's coming into all kinds of contact with people just as the nature of their job. And so remember that prevention not only helps, the general population, but healthcare professionals as well.
Yeah, so I want to move into kind of the treatment potential changes. I know some new guidelines have come out, both from NCCN, and I know, John, you worked with some other folks on some guideline changes. Can you talk about those, and who do you think those affect, and kind of how?
Well, I'll give a brief answer and then let Chris really fill in. I think guideline is the wrong term here. I think it's real guidance, because I think there's different scenarios call for different risk benefit. Just what Chris was suggesting there is, if you're giving curative therapy, that has a higher priority, sorry to say, than somebody who's getting what might be minimally effective palliative therapy. And so if someone's just starting their cancer journey with a new diagnosis, I'm not postponing that treatment through this, because that's a critical time for that patient. If they're in routine follow-up, if they're in the middle months or years of their treatment for metastatic disease, those are patients where I feel like I've got some wiggle room. But we have some basic principles that I thought were common to many of the guidance things that have been submitted, and that is to try and avoid unnecessary side effects. Now, you would think we should do that all the time, but we've always tried to balance intensity of our treatments and with effectiveness, if you will. And what we're saying now is that we can trim some of the corners in some of our recipes that probably don't lose a lot in terms of effectiveness, but dramatically reduce the risk of you ending up in an emergency room with diarrhea or nausea or needing to be admitted from a side effect. So that's where we are. Big surgeries are important, because if you were in New York right now, there's not an ICU bed for you if you needed a post-op ICU bed. And parts of Washington, there are no ICU beds in certain hospitals because they're full at the moment. So we're strategizing about those kinds of procedures because of resources, more than the actual safety, the COVID piece of it. It's just other resources. But I won't go on any longer. Chris, I know you've got a lot to say on this.
No, I mean, that's absolutely right. I will tell you that I was really impressed by John and others. I think you saw a lot of communication when the pandemic really started outbreaking within the United States, between colorectal cancer experts really sharing ideas about how they might deal with this. And I was really, really pleased to see a lot of guidance come from a lot of the experts in the field, and a lot of that communication happening not only kind of nationwide, but worldwide as well. And it's as simple as this. I mean, if you're giving chemotherapy to potentially cure a cancer, right? I mean, if you're giving chemotherapy before surgery, or even if you're giving chemotherapy right after a surgery, where you're really trying to, keep the cancer gone and stay away. I mean, we're definitely going to push the envelope, right? Because the risks there are so far outweighed by the benefits. But just as John mentioned, I mean, there are ways to kind of, reduce the dose intensity, reduce the frequency of giving some treatments, particularly if you're dealing with metastatic colorectal cancer, that can sometimes mitigate a little bit of risk and maybe kind of prevent you from having to come to the hospital too often, maybe decrease the amount of time where your immune system is a little bit compromised. So there's some of these things that I think we've all learned how to do, and honestly learned that well by sharing ideas. And that's really what happened in the first couple of weeks in March, was really, really, really helpful.
Let me echo that, what Chris is saying, because it's, our country has been split, mostly politically, but it's been wonderful to just see how everyone is working together on this. I mean, whether it's our own network of hospitals here in Washington, nationally. I sent out an email this morning to a lot of friends who you know, to just try and ask a question of what are you doing about this particular scenario? And within an hour, I got emails back from people who I know are just as busy as the rest of us to share the information and to try and learn as fast as we can for all of us, right? That's our job. And so and we're not frontliners, remember. So those people who are taking care of the COVID patients are really those on the literally like a war front line, and we're the supply chain. We are back trying to help them with the research. We're trying to help them with understanding how to take care of everybody else. So we've all got roles in this, and it's really it's a chilling thing to feel what's going on there. So I think the public should know clearly that on our side of things, on behind those masks, there's a lot of people thinking hard all day long.
What about folks that have kind of maybe just finished treatment and or are on maintenance therapy, and they're supposed to be coming in for scans? I know you talked about risk benefit, but how are you giving them guidance on when to come in, when not to come in?
Want to go, Chris?
Sure. So for those patients that are currently under surveillance, those scans, the colonoscopies, the labs that we draw, we believe that they're very important. The key here is asking the question, is it critical for that to have happened in March or April, or could I wait until a little bit later? What's interesting is that a lot of hospitals, and this is really kind of state mandated in a lot of places where hospitals weren't even allowed to do elective procedures. And so say you were diagnosed with a colon or rectal cancer, you were treated and you're done with all therapy and you needed kind of a screening colonoscopy as part of the guidelines. You weren't able to actually even schedule it, and even if you were scheduled, you were bumped. And that's the same with certain radiologic procedures, where if you weren't deemed to absolutely have to have it right at that moment, you're kind of pushed off by at least 30 days. And honestly, if that's happened to you, trust me when we tell you it is really okay. The risks of doing the procedure far outweigh the benefits, and that's why hospitals weren't doing them at all. But having said that, also keep in mind that when we start doing this, and you'll see hospitals start doing elective procedures in the coming weeks, that our radiology team has a backlog of 1,600 radiologic scans that they're going to have to get through. And what does that mean? I mean, it probably means that we're going to be running those scanners 24/7 and trying to get through that. But also kind of keep in mind that even when we start doing these procedures, there'll be some delay. But to also understand, it really is okay. If you're in that period, things don't change, kind of month to month in a way that we worry about delaying something until, say, June or July or August.
Yeah. The only thing I would add is we probably overscan anyway. If you really look at the evidence base, we don't need to do it that often. And they've even been randomized studies, and sort of rest of world doesn't scan or test nearly as much as we do. And we do it because we can, right? And, insurance covers it, and we have access and all of those things. So it's hard for us to all of a sudden say, oh, we were just doing that to make you feel better, or make us feel better, quite honestly. But so delaying, as Chris said, is absolutely the right thing. And then, I really do think, Michael, we ought to talk a little bit about the secondary wave, because it's what Chris is referring to.
Yeah, well, that's what I was going to ask, is it's like, the other side of it is, when do we know that it's safe, right? Mm-hmm. So, I mean, I'd love to hear your thoughts. I mean, obviously, there's not a ton of data on knowing when that's going to happen or how it's going to happen. And all of us are just giving, in a way, our opinions. But I would love to hear what that means for patients and how do they think through, all these different aspects. So.
Yeah, as a new business, I'm opening a scanner on a Florida beach, so we're open today. No.
Social distancing, right?
I couldn't resist. I don't know the answer to that, about when it's safe. I mean, what the world's going to look like. I think we are already seeing a secondary wave. I'll be curious to see if Denver is feeling the same thing, is that for first few weeks, patients were staying away from the hospital. And I was worried. I was like, where are our patients that are normally in a hospital, needing a hospital? And they were staying away, and true to form, like this week and last week, it swelled with sicker patients, right? So because they held off till they couldn't hold off any longer. And And I think we'll see, just as Chris says, there's going to be this backlog of screening. And I know that's so important to the Colorectal Cancer Alliance to emphasize screening. So if we put 3 months worth of what would have been screening now into the next quarter and add it up, are we going to see that many more people getting diagnosed, getting surgeries?
Yeah.
So we were talking about, Chris, I'd be interested in your thoughts about, even looking at stage migration, the idea that, if you compare like this few months to the preceding spring times of the last few years, would we see differences in how many patients are presenting with stage 3 and 4 disease versus before? So anyway, I think we are expecting, we're preparing for, another sort of bolus through the snake, if you will, when people do feel comfortable and elective procedures are turned back on, it'll happen.
What's amazing about this is that, John's on the East Coast, I'm in Colorado, and we're basically talking about seeing the exact same things, right? We usually run a census of our oncology inpatient unit of around 30 to 40 patients. We had two at some point. Yeah, 2 patients, which had never really happened in over 20 years at our university. And then all of a sudden, just like John mentioned, it ballooned up. And so I think that it is kind of representative that people understandably were very, very scared to come in. Now they're coming to us obviously sicker. There was this lull where we didn't see any new diagnoses, and now it's starting to come back, right? Even though we're really legitimately right in the middle of the pandemic. And so I think to John's point, some of the things that we see in our younger patients is that they have symptoms for a long time, sometimes a year or more before they get diagnosed. In older adults, it's usually about 28 or 30 days. And that's kind of the reason why we think about younger patients coming to us with more advanced disease. Just like John mentioned, I think that's our concern coming into the summer is that, boy, are we really going to start seeing less stage 1 and stage 2 and seeing later stage disease? But we will be ready to handle that if that comes to be the case.
Yeah, I wanted, the idea of screening, right? So if you're a patient out there and you're having symptoms, that's different. We are talking about people who are fine other than their nervousness about their upcoming scan or their blood test. But if something's not right, we want to get you tested, and we can get you tested. So don't think that we're not open for business for that sort of thing. But so go ahead and have your follow-up televisit with your doc. And if during that discussion you think, oh, we better do a test, then we'll do a test.
And we can get it done. John's absolutely right. That's great advice.
Yeah, so one of the things that the Alliance is doing is in 2 weeks, and I probably should invite you guys to this, or at least to be part of the conversation, because the GI societies have, as you know, recommended holding off on screening colonoscopies, but really there's no recommendation for at-home stool-based testing. And as we see across the country, different places that have lower rates, et cetera, can we have some sort of system? And like you said, is there a tier in which we can start bringing these colonoscopies / other screenings online? Because I agree with you guys. I think there's going to be a large backlog of patients, unfortunately, that are going to be diagnosed later stage. So we're going to try to put a coalition together to see if we can't get this moving sooner, obviously safely. Obviously, there's the whole moral component of putting people out there. We don't know for sure that this disease doesn't live and can be spread in fecal matter, et cetera, but we're trying to do the best we can and kind of moving that forward.
It is passed in stool, by the way. So we do know that you can shed virus through stool. But, again, this is back to opportunity. When crises like this give us opportunity, if we can get another 10 or 20% of our population screened through stool-based testing because of this, and they got nothing else to do, and they're in the privacy of their own home. Let's do it. Let's do it.
Yeah. To that point, the best screening test is the one that gets done. So there you go. Right. Any testing is better than no testing.
Can we talk a little bit about just general research and clinical trials, kind of what you guys are seeing? I mean, obviously, a lot of researchers are not allowed to come into the hospital and the research setting. I know we've heard from a bunch of patients that their clinical trials have been postponed. Can you touch on this and what this kind of means for progress in the colorectal cancer setting? There's kind of the two sides of research that we talk about, the basic science side and the clinical
research side. And so in my offices here at the University of Colorado, these hallways are usually filled with basic science researchers. They have been all kicked off of campus. And so there's only like literally 1 or 2 people that are allowed in just to, allow for some critical things to go on. So basic science, for the most part, has stopped. And so when, in terms of generating new data that requires this thing called bench work, where you're kind of literally at a bench and doing these experiments, that has really, really slowed down. And of course, it's given people plenty of time to then write and analyze data, but that obviously can only last for so long. And so I can tell you that all major universities, including John's and mine, are working on getting researchers back into the lab. But this is a staged approach, right? It's not like a flip of a switch, and we're going to talk about that for clinical research as well. But really kind of the stage approach of really starting to restart research kind of slowly and deliberately, but also to do it safely. And that's largely also dependent on what's going on clinically with COVID-19 as well across the country and in everybody's individual states. For clinical research, that's also been really, really tricky. I will tell you that the patients that were currently on clinical trial have largely stayed on clinical trials. It's because they're on clinical trials because they're probably benefiting from clinical trials. And if they are, it would be so unethical to take that away from somebody. So I think for the most part, patients that have been on clinical trials have remained on clinical trials, particularly if they're receiving benefit. And I'll let John weigh in on this as well. But I think our difficulty has been, our clinical trial operations have really ramped down because of lack of staffing and the lack of the ability to get some of our research procedures done. And so access to clinical trials, particularly in the colorectal cancer setting, has been reduced. And I think there's no other way to kind of say it other than that. Although I think most major universities have been able to maintain several clinical trials where they believe that the benefit was just so high of maintaining these clinical trials and keeping them open, even though it was very, very difficult. So we have been enrolling some patients in clinical trials, but certainly not at the rate that we are usually used to.
Yeah, I couldn't agree more. I mean, clinical trials have gotten so complicated that you need the whole system to be working together in order to pull it off, whether it's biopsies or samples that are spun in a spinner and mailed off. And then you need coordinators who can come to the hospital and visit with patients, which, is trickier and trickier. And then we're supposed to be audited by people and the like. So we've seen it narrowed by companies, by CROs. We've done it some internally. By level of complexity, et cetera. But as Chris said, we've kept everybody on that we can keep on, and we've actually accrued a few over the last month. And then we are now just starting to ramp back up on that. So I'm hopeful that wave of decreased access is short, and we can kind of get back to the business of offering those studies for patients, and particularly in GI cancers where colorectal cancer, where we need new therapies. I mean, the standards are okay, but we've got miles to go. So, and it's in everyone's interest to have that done. So, as Chris laid out, though, too, it's a lot of the back end stuff we've been able to do. So our data is up to date. Our regulatory, reviews, our protocol review committees, our IRBs, they're working. So that's stuff we can do and keep up. So the hope is that when we start to open up, actually, we will have we've cleaned our closets out a little bit, and it'll be a little smoother going forward.
Yeah, so ACS just came out with a survey, and I think it's something like 30% of their respondents said their clinical trials were delayed. So I think maybe, I don't know what you guys think. I mean, there may be a difference between comprehensive cancer centers, et cetera, community oncology. I don't know, but what would you say to a patient if their clinical trial was delayed? Like, what do you
mean by delayed? They can't go on it, or they've
stopped it because of the number of folks, like you said, in the hospital system that aren't, available to make them happen?
Well, I think some of this is that, if day 8 required a liver biopsy and, the IR team doesn't want to do that, then, we either have to get a waiver to breach the protocol or remove the patient from the study. Patient can opt out of the study. So for the most part, my experience has been that we've been getting those waivers, that we've been allowed, patients who are on study, can do that. So that 30% number feels high to me for patients on study. Chris, maybe you've been in the trenches a little bit more than I have. So.
Yeah, no, I think you're absolutely right. You know, I think it's just the level of complexity has increased tenfold, right? So if you talk about the liver biopsy that John was talking about, that's 2 clicks of the button, right, on any normal day. Now it's, you know, probably encompasses about somewhere between 10 and 20 emails just to get that done. And you know, in addition to that, you know, we have a clinical trials office that has 117 staff in it. You know, we have 7 people on the ground, right? And so, and that's really kind of been the difficulty with that. And so, you know, the question of, well, you know, what do you tell a patient where their clinical trial's been delayed or they haven't been offered a clinical trial because of what's going on, is bear with us. I think over the next couple of weeks, you'll see not an instant opening like the flip of a switch, but just a gradual kind of ramp up of clinical research and basic science research. And so, you know, it might be weeks, it might take more time, but I think that in the coming weeks to months, I think we'll get that pipeline kind of back up and running.
Yeah, let me pile on to that, because you need the public needs to forgive us. It's not like we're off, you know, going to Starbucks, the drive-through only. But it's, you know, the coordinator who worked with, just before this call, I was talking to one of our faculty. I had my mask on, and we were talking about. I asked her how she was, and she says terrible. And she was describing a full clinic yesterday, and 3 patients who were on study because her coordinator couldn't be there for personal reasons, personal health reasons. She had to do all these steps, and she was getting frustrated about now the patients were going to be behind and all of that. And she was just expressing that she's working as hard as she can to maintain, but we have fewer hands to do that right now. So, you know, we have to prioritize too in a war like this. And so sometimes those benefits of clinical trials are some of the early things that have to fall off.
So we have about 4 minutes left. I'm wondering, is there anything else you guys can think of? I have 2 last questions after this, but anything else you guys can think of for advice for patients on treatment?
I'm sort of focused right now on positive patients and positive staff. So we're now starting to see our patients who've been being treated or they're in the middle of their treatment and got infected and are now positive, and trying to create some decision tree about what's the right thing to do. And the public needs to also understand that the problem with testing isn't the machines, it's the reagents, it's the chemicals that go to run the tests that are in short supply. So we have to also ration those to some degree. And so obviously the best thing is to test everybody all the time and to only treat people who are testing negative. But we don't always have that luxury. So we're trying to figure out what is the safest time to bring an infected staff member back. You know, they're eager to come back. The patients are eager to continue their treatment. And not some, partly for the patient. There is evidence that treating a patient who's infected is bad. Or makes, you know, they're higher risk for a serious complication. But the same is true for infecting other people. If I've got an infected patient in an infusion unit, if I don't have a separate infusion unit for them, how do I get them treated? So those are the issues that we're struggling with now.
Yeah, just to kind of add on from my side, you know, a lot of my days are kind of spent looking at ramping up clinical research and ramping up the clinical ambulatory and elective kind of procedure, you know, operations. And I think that you'll see over the next couple of weeks that we start to increase all of this. Now, this all has to go in concert with what we're seeing from the statewide level and the nationwide level. I think there's certain states that have really decided to be aggressive in terms of opening up, and it'll be very interesting to kind of see what that means for possible infection rates. And I think just as a word of caution, you know, I think our patient population, honestly, is just very, very smart, very careful. I think that's why a lot of our patients, you know, we haven't really had very many COVID positive patients, thankfully. But at the same time, not to reduce your vigilance right now, because this is as critical of a time as any, just to make sure that we don't open up things too quickly and then kind of give away the gains that I think we've gained over the last couple of weeks.
Yeah, and we don't know what's going to happen, right? I mean, we want to open up. We do so badly, right? And but we're also, when we're the folks that are taking care of folks that get infected, we see that these are real people dying of this problem, and a lot of them. And so we're just, in the absence of knowledge, we're erring on careful. And so, Chris, I think it's right. I mean, the idea of seeing if one of these states that opens up early and it seems to be okay, we're going to be glad to have been wrong and follow along and open up. But we hope we're wrong. Let's put it that way.
So, final question, Chris. I'm going to ask you one, and then John, you one. I know both of you fairly well personally, so this doesn't necessarily have to do with medicine. It has to do with. Does that mean
we've had drinks together? What does that mean?
Maybe. So, Chris, I want to ask you first. You know, I know you work your, you know what, off. You care deeply about patients and their families. You have a family yourself. What are you doing to make sure that, you know, you and your family are safe, and, you know, that you're taking care of yourself?
Yeah, no, it's a great question. You know, I think, you know, within my own family, and I ask our staff this all the time, you know, like, you just got to remember, like, tell me some of the good things that have happened today, right? What are some of the good things that you've seen come out? And I think it's heavy in the hospital. John's going to tell you this. It really is. It's a very, very difficult environment. If you ever wonder if people appreciate the kind things that are said, even just like a thank you or anything, it does. That encouragement means so much. It's important. And just like John said, we live in a very fractured environment. This is as good of a time as any to show how crisis can bring out the best in people. And I think, you know, we want to push that forward, not only on the medical side, but just really, you know, across our country, and the positivity of, you know, just appreciating the hard work that's being done, the knowledge that everybody's just doing their best, and we're all learning together, and we're all in this together. I think that's really helped. I think it's helped for my family. I think it's helped for my staff. It's definitely helped me. And it's even this, right? Yeah. Getting the chance to talk to you guys is really, I mean, it's life-giving, and it's great, and it's what we need. And so, you know, for all of those that are on the call, don't forget how important that connection is, even when it's a little bit more difficult.
Thank you, Chris. So, John, for you, the question is, you know, I can remember back in the times that you were treating my mom, and, you know, she would ask the question about, can I have that drink, and can I go on that trip? And you so eloquently always say, you need to go on that trip, you need to enjoy life, etc. Right now, that's a little harder to say to patients, right? I mean, yes, they can have that drink, right? But what do you say to them to give them hope right now? You know, like you said, there is this like kind of overlying sense of depression, anxiety, etc. What are you saying to patients?
Yeah, no, I think we all are feeling this, right? Not just our patients. I actually think the group I'm most worried about, and I'll come to patients in a minute, is really like the 20 to 30-year-olds right now. Many of whom are now suddenly unemployed because of the kind of work they were doing. And we're trying to sort of map their way anyway, and they already were sure the world was going to hell. And so now this, and so that age group really worries me, of seeing a future, seeing some sense of hope. But we have stuff to do, right? We get up in the morning and our brains are immediately thinking about things, so we're engaged. Our patients on some level also have a job to do. They're focused on their treatment. Now, Michael, your list that you ran off at the beginning of this is a long, terrorizing list. I mean, from access to insurance to trials and all the things that are with cancer patients that are already just trying to hold on to what they have. I think our patients have done, as Chris said, remarkably well with this added one more thing to juggle on top of everything else. But you do sense the sort of, I don't know if it's boredom or anxiety or that's starting to bubble up. And I do think we are about this. Part of the next wave is an emotional one. The economic hit is clear. The medical viral thing is clear. But I actually think there's going to be an emotional trail that's left, and not just among our patients, among our staff and the like. So as the sun comes back out, and we can't stop what Chris said. We got to keep watching out for each other. We got to keep being a good neighbor. Keep waving while you're on your walk to people you've never waved at before. If you're doing, I wave it. I look like the crazy old man on the.
Me too.
Everybody, I don't even know, I'll wave at anybody and say hey, and I'm hoping to keep that going as we go forward. And as Chris said, I am hopeful that this experience, this shared global experience, will put us in a better place in years to come. So fingers crossed.
Well, I can speak on behalf of the entire community that you both are incredible human beings, great doctors. No, it's true. And you inspire a lot of people. You will continue to save lives. And I love you both. And we will certainly get through this together. Love your butt, John. Thank you guys so much. Stay safe and healthy.
Thanks.
Thank you so much, everybody. Appreciate it.